Hello everybody, this is Angel, second year MBBS student from Dr. VMJMC Solapur. I would like to take this opportunity to present a case in front of you all. A 42-year-old woman who has had proteinuria for approximately 5 years develops renal failure. She also has developed hypertension and has had several bacterial and vaginal yeast infections over the last 10 years. Her pregnancies were uncomplicated, although she required C-sections for large babies of 9 and 9.5 pounds. A kidney biopsy reveals increased mesangial matrix and acellular periodic acid shift positive nodules. Let us now go through the findings one by one. Now obviously, because we see a glomerulus in the biopsy, it's a glomerular lesion. Glomerular lesions, as we know, are mainly divided into nephrotic and nephritic syndromes. Briefing you on the main differences between them, nephrotic syndrome occurs due to deranged capillary walls, due to which there is increased capillary permeability. It presents with massive proteinuria of more than 3.5 grams per day, which includes albumin as well as globulins, and the patient is particularly vulnerable to infections. The patient also suffers from hypertension and generalized spitting edema in the dependent portions of the body and also has hyperlipidemia and lipiduria. Nephritic syndrome, on the other hand, usually presents with hematuria and red cell casts. The patient also has azotemia and oliguria. He or she suffers from mild hypertension and mild proteinuria and edema. Since the patient has predominantly shown proteinuria and hypertension in the recent years, the scales tip more towards nephrotic syndrome. Coming back to the biopsy, we characteristically see sclerosis in the glomerulus in the form of nodules. The patient has also had several infections in the past 10 years. Also, the patient's babies have had excessive birth weight as newborns. This is also called macrosomia. Nodular glomerulosclerosis, repeated infections and macrosomia characteristically suggest diabetes mellitus. We therefore can conclude that the patient is suffering from renal failure due to diabetic nephropathy. Infections in diabetes mellitus can happen due to impaired WBC function, reduced cellular immunity, poor blood supply due to peripheral atherosclerosis, hyperglycemia, loss of immunoglobulins in the urine. Diabetic nephropathy, occurring due to microangiopathy, manifests mainly as glomerulosclerosis, arteriolosclerosis, or pyelonephritis. Earlier microalbuminemia and later macroalbuminemia occurs if there were no interventions done. Also, the person develops hypertension. The sclerotic nodules in diabetic nodular glomerulosclerosis, also known as Kimmel-Steele-Wilson disease, may enlarge to obliterate the glomerular capillary tuft, which may lead to ischemia, tubular atrophy, and interstitial fibrosis of the kidney. Poorly controlled diabetes during pregnancy can cause macrosomia, irrespective of whether the diabetes is pre-gestational or gestational. It can also lead to long-term sequelae, including obesity and diabetes themselves in the baby as well. Well, how does diabetes mellitus chronically affect different organs and systems of the body? They are basically mediated through advanced glycation end products. AGEs are formed by non-enzymatic reaction between glucose derivatives and proteins. They cause the release of growth factors like VEGF or TGF-beta and cytokines and reactive oxygen species, etc. They cause the cross-linking of collagen in large vessels, which leads to shear stress and endothelial injury due to decreased elasticity. There is decreased endothelial cell adhesion and therefore increased extravasation of fluid. Albumin binds to glycated basement membrane, which causes it to thicken, basically being responsible for microangiopathy. It also promotes cholesterol deposition, leading to accelerated atherosclerosis in blood vessels. Also, excess glucose gets converted to sorbitol in the cells, which in turn forms fructose. This process uses up NADPH, leaving very few amount of it for the regeneration of glutathione, which leads to oxidative stress. Increased amounts of fructose 6-phosphate formed promotes formation of excess proteoglycans that further play a role in organ damage. Coming to the differential diagnosis, the other possible explanations from the biopsy are amyloidosis and systemic lupus erythematosus. Both amyloid and glomerular sclerosis under H&E appear as pink amorphous material. Nephropathy in lupus also can sometimes present as glomerular sclerosis, just like diabetic nephropathy. The measures that can be taken are control blood sugar levels and hypertension, insulin and oral antidiabetics like metformin and DPP-4 inhibitors or GLP agonists or sulfonylureas as adjuvants can be given. For hypertension, ACE inhibitors and angiotensin receptor blockers are primarily given. Until proper control of the primary cause, that is diabetes, dialysis is needed for renal failure present at the moment. Proper diet and regular exercise are also highly recommended in day-to-day lives to keep diabetes at check. And that is all for this case. It was elementary, my Watsons, wasn't it? Stay healthy and stay safe. Thank you.